I'm in Tucson, Arizona. I'm at a pretty nice hotel. You don't really get much of a feel of it there, but it's got, I couldn't ask for anything more. Good view, by the way. Well, a little bit of a view of a parking lot, but I mean, it's nice. You can sort of hang out there. But I'm not here to hang out. I'm here for one thing and one thing only. That is to get to where I'm trying to get to. I'm here on behalf of a company, and they are partnering with me to help me train myself in how to treat arteries using a laser. So with this laser, we can improve blood flow to the arteries and to the tissues, the toes, the legs. We can make things better. Importantly, we can use our IR skill sets to their best advantage. Again, IR, in my opinion, really is a skill set more than anything else. You could call it a specialty, you could call it a subspecialty within radiology, but really it's just it's a skill set. It's needle, wire, catheter. It's a Seldinger technique, and you can apply it to so many different organ systems, and it's up to you to decide where are you providing the most value for yourself, for your patients, where are you getting the most bang for your buck. I think treating peripheral arterial disease is probably the most serious use of your skills. This is as opposed to, for example, doing a paracentesis. I am interested in treating this disease. This is a disease that's very prevalent, and it's very life-limiting, and it is also treatable. It is treatable. It's reversible. Probably the best thing you could do is exercise. So that's something that you should be advising patients, you should be doing yourself, trying to get that blood flow down there. But there's a whole host of techniques out there. There's the balloon, there's the stent, and then there are some really, what I think are newer things. Now, I think they're new. Other people probably have been at this for a while, but basically you can drill out that plaque, and apparently you can vaporize it with a laser. So that's what I'm interested in learning about, going into it with an open mind, and just opening myself up to new possibilities. I think, hospital-based IR, the hospital really dictates what you do, to a large extent. A lot of it is stuff that you don't even see, and I hate that, I don't like that there's a young generation of IRs that are really being gaslighted, for lack of a better term, gaslit. Basically, there's gaslighting going on. You go to a hospital, you're excited, you're full of energy, you're right out of your fellowship, and you really want to build that IR service from the ground up. And there's always going to be someone there telling you that, yes, you can do it, you can do it. But I'll tell you what, growing an IR service, you need fertile ground. And as an IR fellow and recently attending, you don't know what that is. You really need substrate. You need a decent substrate. You need a decent place to really build IR if you're doing it in a hospital. You need, I think, 300, 400, 500 beds. You need people that are interested in referring to IR. You need patients. You need patients with cancer. You need patients with ESRD. You need sick, dead, dying patients in the ICU, and you need ICU doctors that will do whatever it takes to get those lives saved. That is where IR can be valuable in a hospital. What you don't want, and what I see a lot of people unfortunately getting into, or I've certainly gotten into myself, is you don't want a 100-bed hospital that wants you to clean out paras and thoras. Now again, those are important pieces of work. They need to get done. Who they get done by, if it's done by board-certified interventional radiologists, it's done to the highest level, and that's a good thing. But again, the skill set can be used for so much more. So I'm about to head down, head out to dinner, and like I said, I'm excited to learn how to use a laser to treat peripheral arterial disease. What I think is the most interesting use of my skill set that I can think of so far. Struggle MD.